Hello, everybody. It's a great pleasure for me to moderate this interesting session. I'm sure everybody will enjoy the very well selected cases. And thanks for the organizers for giving us this opportunity to see and learn from each other and cases from all over the world by Jack cases and local cases as well. So we're going to start by a very interesting case. As a moderator, I've seen the cases before, so I'm really sure that you will enjoy it. With Professor Rafael Vidal Perez, it's a case with the title of Case Complications on Ischemic Heart Disease. Rafael?
Yes. Thank you so much, first of all, for the invitation to share JACC case reports, but only some of my cases, I have to say also, because there are some part of them. So I will share my screen now, and I bring a bunch of cases, more than I will show you cases that from JACC case reports and some from mine. And this is my presentation. First of all, thank you again for the invitation, and I go with the presentation. This is the first case. It's a 70-year-old man admitted at the coronary care unit after PCI of a complex stenosis in the left anterior descending coronary artery due to ACS without ST elevation. 18 hours later, the patient has a episode of atrial fibrillation or short duration, and we decide to perform a new transthoracic echo. I have to say that was one of my first words after ending the training, and I find this. So as you can see here, that there is something that we don't know because we don't have the first echo. It's the first echo after the PCI. I open the discussion with the panel. I think you know it, but I want you to discuss a little, if you want, what do you think it could be: asymmetric hypertrophic cardiomyopathy, myocarditis, myocardial edema, some storage disease that we don't know, amyloidosis. What do you think? I know that probably some of you check the cases, but the others, what do you think?
We go back to the echo image again.
For one moment, I play again.
Yeah, so as you said, this the picking item here that we have hypertrophied septum, but which show a kinetic movement. So I will exclude that this is HOCM or hypertrophic cardiomyopathy, and I go that something localized in the septum. Having the history of that the patient have chest pain, so the storage disease will be also to somehow excluded, and I will be between P and C. Is it myocarditis or hematoma in the myocardium? I don't know if you agree with that thinking.
I think it's the point. I think it's that could be the discussion. In this case, with a myocardial hematoma, because we review the images later. It was a case that we have in you can see here there was some complication unnoticed during the PCI, but it was in the image. That sometimes you have to come back and review your image. So I think it's very. The one learning point is that sometimes you need to see back the coronarography. It's not only stand and listen. It's something else sometimes. No, it was an image that was in the JACC when the cases were not in JACC case reports. I have to say, and this was the MRI. You can see here. I don't talk so much. It shows you that you can have cases that then could be also in JACC case reports. So don't miss the opportunity to share your cases because it could be something of interest. This is my first message. You can see here that after 2 months without doing nothing, in this case with conservative treatment, we get to the right situation again. Here is the CMR of the situation. You can see how it was at the beginning with the blood there. So you have the edema around the lesion. So it's interesting how it was the evolution and the late gadolinium enhancement. So it was the evolution of this case. So this is something rare, but no complication of myocardial infarction, probably after also sometimes some procedures. In this case, you see what happened before. And it's very useful contrast and magnetic resonance. So many times you can go for something conservative. Sometimes maybe you need to go to something else because it can be more complex. This could evolve maybe to a rupture. It depends. So why I show this case? Because we have this case in JSK report 10 years later, and I think it's more spectacular. This is a 55-year-old man, active tobacco smoker with a known history of diabetes, hypertension. He came to the hospital in class 4 of New York Heart Association. And we asked with the author so asked that he has a chest discomfort 1 month before, and was resolved spontaneously. The patient had tachycardia, low blood pressure, data of right heart failure, and there was no more previous history. It was a case from India. You see all the T negative T waves. In this case, you can think that something happened, and probably it's an evolution of myocardial infarction, probably, but 1 month later. And this is the image that I think it's really, really spectacular. What you see here in this case, it's more how to say, more bigger than the one that I showed you, and you can think that it could be more complex. Of course, you have to do a differential diagnosis, and they make a great differential diagnosis here. In this case, you will show here they use the contrast to show that this was not a thrombus. There's something different. That's something that is is a myocardial hematoma. And here is very important in the 3D. You can distinguish blood. You can endocardium, myocardium inside. So this is important. I think we will discuss it probably later. This is the MRI. You can see the images, I think, are really, really nice, and you can see the big myocardial hematoma or the late gadolinium enhancement of the myocardial infarction. So I think it's a case very interesting and also spectacular. These are more or less the summary of the case. I think this is also good to show that it was a patient that it has this myocardial hematoma, severe LV dysfunction, this acute descompensated heart failure, and they stabilize the patient. And then here, I think it's one of things of debate. We have to evacuate this. We can leave it like it is. I think it's something that we could discuss. If they decided to manage the patient conservatively due to this preventive risk for surgery. But in some cases, maybe you have to decide if you have to go for something else, if you have to go for surgery or not. That's one of the doubts. But usually the approach, it's this conservative management. It is a small hematoma. In this case, it was a big one. Probably you will think on surgery, but you have to balance risk. I think it's important to think which are the reasons where you can have high mortality, that is low AF, old age, anterior MI like this, cardiogenic shock, he entered with heart failure, this late diagnosis 1 month later. So it's interesting. I don't know if you want to focus a little bit or not in this part of the case. I have another one for continue. I don't know if you want to make some comments.
For the sake of time, because you are really presenting very nice cases, I think we need to move on better.
Okay, perfect. I will move. Well, this case was published also on social media, and it was interesting because of a big debate asking if go to surgery or not, discussing if it was different, the management depending on the country. There are some differences depending on the health systems. Well, there was a lot of discussion. And I will show you now with the COVID, we had a lot of cases related with COVID. Julia will take this also, but I think we come back again to ischemic heart disease cases that were, how to say, forgotten, because now we see this evolutive case that we have different situation, cardiogenic shock, no reflow. There are a lot of interest. There are editorials in the journal to read what is the impact on this. In Spain, we see this. It was published in Spain that we have less intervention, less diagnosis, less PCI related with COVID. And there are a lot of cases within a SKY collaboration. I recommend you to go through them. And and there is a nice editorial speaking all the potential complications that we came back again with this late presentation of STEMI. They will have a first series of Italy when they have the start of the pandemic, and also in other places like in New York, we have these cases. There are many good examples. As again, you can have this in JACA reports, but you can have it on real life. Or you can have also complications like a rupture, and really spectacular cases. As you can see here, 3D for the papillary muscular rupture. But as I told you, we can have similar cases on your daily practice. This is a patient, 70-year-old man, smoker, obesity, diabetes, presented to the emergency department with 1 month of soreness of breast. Again, and if we come back, he had a history of something 1 week before. He was stable at the entrance, and these were the analytics. We have elevated NT-proBNP. The troponin was near normal, but we have a high dimer. You can see here also again that probably something happened before, a Q wave. This was the X-ray. As you see here, they have doubts if it could be embolism, and they performed the CT scan. As you can see here, we have this important effusion, pericardial effusion, and this was one of the things that worried most. So you can see here, and they ask for an echo, and this is the first echo. As you can see here, you is a patient with a bad acoustic window, I have to say, but you have this pericardial effusion, and they go through this, and you can see here this structure that makes with these anomalies can start to think, what is this? This is an aneurysm, pseudoaneurysm. I think this is the discussion. This was the first echo. A second echo was made because of study better the case, because in the first echo, this image of the aneurysm was not identified clearly. Here, this echo was more focused. You can see here all this defect that we have. They still focus on the time of what to do with the pericardial effusion. That it's another thing of interest when you have doubts of what's going on with the myocardium. Sometimes you have to go or not through pericardiocentesis. So this patient was sent to our center for surgery because they have this interesting CT scan that you can see here. It's probably was more indicative of pseudoaneurysm, because if the neck was narrower than the cavity, the acute angles, inferior location could make you think on this complication. And of course, cut was made, a 3-vessel disease, but not good vascular beds. And at the end, it was decided to make a surgery to go through this, because it's a pseudoaneurysm. You have more implications and risk of rupture. You can see here image of the surgery. This is also part of the pseudoaneurysm. This is the final result. You see here a patch. You can see that always there is a little pass of something, even because it's a surgery in a, how to say, acute phase. Sometimes the result could be not so perfect, and you can see all this structure that is with the patch, all the pseudoaneurysm close. But again, this is something that it showed you. This is the case that we will have soon, also published from other people. Of course, there's how to distinguish true or false aneurysm. I think it's something interesting. This is a case about a patient with tachycardia, and through the studies we get to this difficult diagnosis again, and you can see perfectly in this case documented with all the imaging techniques how it has to be studied, this entity, to know if it's aneurysm or pseudoaneurysm. I think it's a great case that I recommend you to look for. I think this is reconstruction on all the planning, how it's have to see on CT, on MRI, how you can distinguish that you are facing a pseudoaneurysm. And it's one of the biggest, I think, that we can see published in literature, that it's this big neck. But the most thing I could say that is more spectacular also is how to see all the surgery. I want to share with you the video. I think it's like 1 minute, and you can see all the procedure, how they open the pseudoaneurysm. I think it's something really amazing. Then they look for the thrombotic material that you see in the multimodality imaging. They are going through it in the next seconds. They are opening the sac first, and then they will put out the material. I go forward. I think thrombus removal, as you see, and the next steps is cryoablation to close this neck. Then pseudoaneurysmectomy, and then they are going to close all the gap and close the structure. I think it's something really nice to see because it's not a common surgery, I think. So I suggest you to, if you have the opportunity to check the case. I think the take-home message is very important. Why to distinguish these entities? It could be evolution of my first case to go to some kind of rupture. It depends on the location. And of course, if you have a true aneurysm, you can be more, how to say, less urgent. You can be more quiet because the risk of complication is not so high, and the 5-year survival could be great. But when you have a false aneurysm, you have a very high risk of rupture, and this is with high mortality associated. I think it's important the value of the multimodal imaging because sometimes you have some clues to know if it could be one thing or the other. And I think in this case, the main point is the value of multimodality imaging. In this case, usually you have to go to resection, knowing that the mortality is not low. And more if you have problems with the valves. In those two cases, as you see, there was not that problem, but it could be also sometimes associated. And that's my part. I think I saved my time, my 15 minutes, but I think we can have some minutes to discuss these cases.
Thank you so much, Rafael. Thanks for the great cases and thanks for sticking to the time. As we have 1 more minute remaining, I prefer not to jump for other cases. Maybe I just need to ask one question, and with the help of the many MRI experts and from what I see now, how can we differentiate for the second case, actually, the big apical hematoma? How could we say, if we can get the slides, that this is the endocardium, not just an organized shell of an LV thrombus, because treatment will be totally different. One will just give a thrombolysis or heparin, and the other one is contraindicated to give this. How were you or the team, treating the case, we're sure that this is the endocardium, not just an organized shell of a fresh thrombus, because it can give you the same appearance?
Yes, I think one of the points is all these, as you see in that video, I think it's all this 3D mapping thing, I think is very important. And also the late gadolinium enhancement can give you some clues. Sometimes it's not full, it's not a complete transmural thing. And so you can have some clues that there are some endocardium. I think the point is get some endocardium. If you get to see some endocardium, then you can start to think the other part could be pericardium only, and that is the main thing. I think it's if you can have that. Of course, with a thrombus, I think it's when it's complex. The point. I think they are the most tricky cases, but I think this approach of multimodality imaging can give you a lot of help.
Yes, great. So thanks, Rafael. We'll go right away for the second case. It will be with my friend, Professor Julia Grabsa. It will be top cases from COVID-19. Julia?
Thank you very much. I will share my case. 1 second to share the screen. Thank you very much for the invitation. And let me minimize. So it's a great pleasure to be here. Again, as Rafa's presentation was amazing, and the same as he explained for JACC case reports, the same we did for COVID-19. We started collecting cases from March, and the plan was to have a dedicated issue on COVID-19 in July. And we collected the best cases from across the globe. Also, we waived the fees for publication, so we want to publish the best case as soon as possible and without any, with trying to help also the authors. So I'm a consultant cardiologist at St. Thomas. I'm here also at the moment. I will start with the first case. And this is an interesting case of 58-year-old woman presenting with productive cough, fatigue, fever, and diarrhea for the previous 5 days. And of course, she was hypoxic, 82% on 5 liters of nasal cannula, heart rate of 130 beats per minute, and the temperature was 38.7. Now, the impressive here is there are the diffuse changes. Of course, it's tachycardic, but if you see, she has some upsloping ST elevation on 1 and AVL, some minor ST depression on lead 3, and also diffuse ST changes across the ECG. So we suspect that there is something wrong with the myocardium. And then the first line also, what we did also with COVID is we were performing fast scans. Here it was at the beginning of the pandemic, so they kept the ECG leads on. But during the pandemic, we removed completely the ECG leads, so we tried to have the minimal contact with the patient. And what you can see is the typical distribution of, or suspicion, of course, of stress cardiomyopathy. So this is finally the patient went for an angiogram. The angiogram proved to be normal, and the patient had Takotsubo cardiomyopathy. And this was one of the first presentations of Takotsubo cardiomyopathy. You can see here the distribution of the myocardium, that of course then the patient was treated in intensive care unit, and the myocardium returned back to normal function. So this was one of the cases that received a lot of attention, and because we saw during the COVID-19 pandemic that Takotsubo was rising, and it was coming from two parts, not only between the patients because of the viral trigger to the myocardium, but most importantly also that they had a lot of broken heart syndrome among patients, but also among physicians. So we saw a study from Cleveland Clinic that they described a lot of Takotsubo among caregivers, among doctors, nurses who dealt with the pandemic. But also we had, for example, a case that they described a caregiver who felt emotional during when we were clapping. Especially in I don't know if you had this in Egypt, but for example here in London, in Spain, I think in Portugal as well, we had, for example, every Thursday at 8 p.m., the people would go out and clapping for the doctors who were helping. So the second case, I will move to the second case and then we can discuss at the end, is an 18-year-old male without any prior medical history. And he has, again, cough, fever, fatigue, and myalgia. And he has his tachypneic, he's slightly tachycardic, he's maintaining his saturation, and of course he's diagnosed with COVID. And then on day 2 we can see the distinct changes on the X-ray and on the CT scan. I would say that the cardiothoracic index is slightly elevated. That sets the suspicion of cardiomegaly. So, but then on what happened is the patient quickly deteriorated. On day 3, he presented acute respiratory distress, severe hypoxemia, and his oxygen saturation decreased to 82%. His lactate was impaired to 2.2, actually 14, so it is quite deranged. The cutoff is 2.2. And here there is a mistake, I apologize for that. The troponin was 11,000. The BNP was 9,000. So both elevated, significantly elevated. And then, of course, we do an echo. And the first thing, before we did an ECG that demonstrates some T-wave inversion in leads V2, V4. And again, we are thinking what's happened. It's not, okay, except for the T-wave inversion, I cannot say that's super impressive because then the patient went to have an echo, and that shows a very decreased ejection fraction. The ejection fraction was 30%, very poor left ventricle. And, we are thinking a young patient with very poor ejection fraction, having a viral condition such as COVID that we knew at the beginning that was quite aggressive virus. And would it be fulminant myocarditis? First, we set the suspicion because of the distribution. The patient then had an MRI, and then this is the comparison of day 7 and day 14. Day 7, he was still actually on support, inotropic support, And despite that, they want to do an MRI to see whether the underlying cause would be myocarditis. And indeed, they detected myocardial edema. And the ejection fraction on the left is approximately 40%. With treatment, it started gradually improving. But the most remarkable is that we compare a direct comparison between day 7 and day 14, when the patient is off intensive care unit, off any kind of support, and you can see that the ejection fraction has almost recovered. And this is another view, of course, that on the left you see a sluggish ventricle, that it's affected by the virus. The patient had fulminant myocarditis, is significantly impaired, and on the right again recovered. And here is another view of the comparison between day 7 and day 14, that there is significant improvement of the contractility. Now, even as a proof, we love this case because the authors actually are doing their best to set the stamp and say why it was myocarditis, why we did the sequence of the follow-up with MRI, and we have the improvement of the function. So you can see the evolution of T1, T2, and the extracellular volume between day 7 and day 14. And there is a significant decrease of ECV in the posterolateral wall on day 14. So there is a significant difference. It makes a difference to treat COVID patients, because then you will see a reversal of the myocardial function. So this is important because we saw a lot of patients with COVID-19 pneumonia, and we saw a lot of insult to the myocardium. So they would suffer either type of myocarditis, or of course the right side of the heart would be impaired, because we know that the virus was unfortunately very thrombogenic. Or of course we saw Takotsubo. Here we have a direct influence of the virus on the myocyte. And later on, we started receiving also some cases that they did biopsy the myocardium. At the time that this case was submitted to us, of course, the MRI, we thought that it's a very stable proof of myocarditis, and it is. So this I will be very brief, only as a supplement to what Rafa said about the stent thrombosis, and he explained, actually he showed few cases that we have accepted JACC case reports, but this was a case during COVID-19 pandemic, that a series of patients that either they had the PCI a few hours earlier or a few days earlier, they present with acute stent thrombosis. And then the author successfully did OCT to show the thrombus, the mixed thrombus, and how it presents. So it was very interesting to show that this virus, as I said, is quite thrombogenic. And it became a part of the news because many newspapers were quite interested, Medscape, TCTMD, Reuters, and they interviewed the authors because it was the first time that was described around June. And then we saw indeed that the patients suffered a lot of events because of that. Like a summary, sometimes we say that's very important nowadays to go to the hospital when a patient with COVID-19 experiences different symptoms, or to monitor the patient, to describe, for example, to do a triaging over the phone, because we do a lot of teleconsultations and video consultations. So, and to be aware that COVID-19 pandemic can bring these problems to the surface, such as arrhythmias, thromboembolic events. We saw a lot of patients with PEs, patients that they have not recovered yet, or, for example, that their right heart is impaired with high thrombotic burden, also coronary events, and of course, very important, heart failure. I saw yesterday, for example, on social media, a patient who was 5 months on ECMO, and yesterday he had a successful lung transplant. So this is a miracle, because unfortunately here, the patients that they were in ECMO, 15-20% they recovered. The rest, unfortunately, they had so many thromboembolic events that they died. So And as Rafa showed, just to implement the important study from Spain, from Dr. Oriol Rodriguez, he was the first one to describe that there was a 40% reduction of ACS syndromes, the first in the world, during COVID-19 pandemic. Then the people from the United States, they described exactly the same percentage from Sky. And then we thought to present this editorial on why actually we see a lot of delayed presentation now of STEMI with the COVID-19 pandemic. So as an advice, of course, it's better to screen the patient, to ask for chest pain, even to do an ECG. We had a case that a patient went to emergency department 3 times. They measured the temperature, they measured blood pressure, they didn't do an ECG. So this is very important. I think the primary aim of this lecture and in general when we speak about COVID-19 is to raise awareness around the cardiovascular complications. Thank you very much for your attention.
Thank you so much, Julia. Very interesting and very informative as usual. You were kind enough to give us 2 to 3 minutes for discussion. So the floor is open for any of the...
So allow me, Hani. Thank you, Julia. Very interesting and provocative cases, actually. Let me ask you, first of all, it seems that we have to find something to differentiate between perimyocarditis and acute coronary syndrome before doing unnecessary angio. This is the first question. The second short question is that in view of stent thrombosis, is there any recommendations to put patients with stent during the pandemic on some anticoagulant therapy?
That's a great question, Professor Reda, because there is at the moment a study undergoing in 100 centers that's called Freedom COVID, and it's direct testing 3 different types of anticoagulation. Because we do not know actually these patients, if what the author suggests practically is that depending on the presentation, they kept them on long-term double anticoagulation. In some patients, they also added warfarin. So we don't have a firm study, but it would be very interesting to see those patients, because the 100 centers is a large study taking place from the NIH in the United States to see the results. But I can see on forums that there is a lot of stress on how to treat these patients. And, it's what we could do is depending also on the bleeding risk. That's very important. So quantifying everything and then take it from there. Now, it's also another interesting point is how to differentiate the myopericarditis from the ACS while actually not taking the patient in through the scanner. Because I was wondering who were the people who took the COVID patients through an MRI scanner. Here in England, it was forbidden. That's for sure, because we would infect somehow the scanner. But as you can see from this case, they took the patient to the scanner also twice. Now, it would be better to do an angiogram, and that's how I think we would exclude ACS, and then we would be driven to myopericarditis case, and then of course from troponin, BNP, and all the rest. I'm not sure if I would suggest Ricardo, for your experience from Portugal, if you were taking the patients to the scanner or not.
Okay, hi everybody. So it is a pleasure to be here with you all, with all colleagues from Egypt. It is an honor and a pleasure to be with you. Just a brief comment. I think Julia told a lot of things. She showed a lot of interesting things regarding what we know nowadays regarding the cardiac involvement in COVID. She talked about a lot of things. The first thing that I would like to stress is probably, although we know that the heart is involved in some COVID patients, as she showed us in myocarditis, in acute coronary syndromes, etc., I think that from a cardiologist perspective, the greatest concern that we should have is with the non-COVID patients that are not coming to the emergency department. Julia told us this. We are now having a lot of data coming up, for instance, from our country, showing that the number of mortality which is not related with the COVID, the non-COVID patients, actually is greater than the mortality associated with the COVID situation. So what is happening is that people, because they are afraid, they are not coming to the emergency departments, they have acute coronary syndromes at home, and then they die at home, or sometimes they come with very delayed complications, and we are seeing this more and more often. Going more direct to the question that Julia asked me, what I think it is more reasonable is, of course, first of all, do a good clinical integration of the data that we have. Not only a good clinical history, integrate the EKG, which is important in this kind of situations, to differentiate between acute coronary syndrome and also myocarditis. And in case of doubt, I agree with what Julia said. First, send the patient to the cath lab and not at the first hand to the MRI, because if you send the patient to the cath lab, we are now used to do cath to COVID patients with all the protection measures. It is now nowadays something that is a standard procedure. We know that it is safe if you use all these kind of protection measures. And I think the message is, if you have doubts, send the patient first to the cath lab to clarify the situation. Then, if you don't have significant coronary disease, you have time to do the MRI or to do any kind of test. You can wait 1 or 2 weeks, because probably in most circumstances, it will not significantly change the approach to your patient. Just to conclude, one final thing. We are starting to understand, for instance, last week it was published a Lancet article showing that even in young populations, more than 50% of the population with COVID have some kind of pericardial involvement. Usually this is a subclinical involvement of the pericardium. You have some pericarditis, but you don't have symptoms. And this is interesting how this virus has some tropism to the pericardium, but also to the myocardium, although in the myocardium is quite rare, as Julia said.
Great. Thank you so much. Very informative, Ricardo. Thank you. Now we have to move on for the last, but not the least for sure, presentation by my friend, Professor Ahmed Asfour, who is in both an interventional and an imaging expert as well. So Ahmed will speak about the hypertrabeculated non-compact RV in HCM.
Good afternoon, good morning, wherever you are, everybody hearing me. It's my pleasure to be here with you. Let me start immediately. My case is a 19-year-old male patient. He doesn't have any special habits of medical importance. He denied IV drug addiction, not diabetic, not hypertensive. 5 years ago, he was diagnosed as hypertrophic cardiomyopathy patient. Then 1 month ago, he developed severe high-grade fever, shortness of breath. That was in the era of the pandemic. That was I think, in July. CT was highly suspicious for COVID, so he was admitted in the isolation hospital and was diagnosed with COVID-19 pneumonia. And that was his CT chest. We can appreciate the consolidation in the right lung. His lab work showed high TLC, inflammatory markers, ESR, CRP high, probably multi-organ damage, elevated INR, but eosinophils were 0. His saturation was maintained. His ECG showed sinus tachycardia with ST depression, strain pattern probably from his hypertrophic cardiomyopathy. And that was his echocardiography. So you can appreciate how severe the hypertrophic cardiomyopathy. It's like 2.5 centimeters, no significant SAM, mild pericardial effusion. But you can appreciate here something notorious in his right ventricle. There is like obliteration in the cavity. We are not sure what is that. no significant LV outflow, tract obstruction, mild tricuspid regurgitation, but again, you see the RV is obliterated. So now we have a problem. This is a patient with pneumonia, COVID, septic shock, multi-organ damage. There is an RV mass. He has LVH, hypertrophic cardiomyopathy, and multiple bilateral pulmonary lesions and consolidations, electrolyte abnormality, some anemia, and subhypoalbuminemia. He was in a septic shock and he was resuscitated. They gave empirical antibiotics because his COVID-19 culture were negative twice, and actually blood culture showed MRSA. So now the patient was diagnosed clinically as COVID, but the swabs twice were negative. He went in a septic shock. His blood culture was bacteremia. He has multi-organ damage. He has something in his right ventricle. We don't know what is it. So what are the differential? So she went through the hypertrophic cardiomyopathy spectrum phenotypes, whether the hypertrophic has something to do with his sepsis, whether this RV is a thrombus that's infected, or a tumor that's infected, or it's endomyocardial fibrosis, but actually his eosinophils were 0, whether it's other storage disease. We went through the differential quickly, that his blood culture. Obliterated RV with a chest infection, actually it's not the case. His LV didn't show obliteration and his eosinophils were 0. Whether that's just association, hypertrophied RV, which is common with hypertrophic cardiomyopathy, hypertrabeculated RV, like in this case, and then he has septicemia for other cause, or maybe lung infection. Is it a Behçet disease? It's common in Egypt, common in young Mediterranean fevers, and this RV mass is a thrombus, and patient has fever and constitutional symptoms, but actually he didn't have any oral or genital ulceration. And ophthalmology consultation excluded Behçet. Could it be a sarcoid heart disease? Well, actually, sarcoid can present with hypertrophy. It can cause some fever, granulomatous changes in the lung that might get infected, but RV thrombus is not common. Patients usually develop some sort of ventricular arrhythmias or heart block. That was not the case. And usually the sarcoid present with some sort of LV dysfunction, and it's easy to be diagnosed by cardiac MRI. It has a special pattern of enhancement in the septum usually. Is it just an infected thrombus? There is pathogenesis for the thrombus. Maybe he's an IV drug addict, and there is some contamination and endothelial damage in the RV that triggered the thrombus, and the thrombus got infected. So that was our differential. So we decided to go through the workup for this case, and cardiac MRI was needed, because if it is a thrombus or a tumor, then we will have to resect it, because the patient will not recover with just antibiotics. That was the whole workup. And the CMR, here we go. So from the CMR, from the SENI images of the CMR, we can appreciate that this could not be hypertrabeculated RV. You can see that the mass is not attached to the wall. There is delineation between it and the wall. And you can see the pattern of the hypertrophy looks just hereditary, genetic inherited hypertrophic cardiomyopathy, because the thickened part looks that contracts, and there is asymmetry between the septum and the lateral wall. It could be sarcoid, but I would go more for just hypertrophic cardiomyopathy. And the RV, you can see that the RV is a little bit impaired, but the mass inside the RV is not hypertrabeculation, is not RV lung compaction. There is something in this RV. It could be a tumor, it could be a thrombus. The T2 weighted images, we don't have T2 mapping in this facility, so we just opted to conventional T2 weighted images, and you can see that this mass has hyper intense signal in comparison to the myocardium. The first pass perfusion actually confirmed that this is a non-perfused mass. So we discarded the possibility that it's a tumor. And then we think from this perfusion images that it is a thrombus, and it was confirmed actually on the early gadolinium enhancement that the RV is occupied by thrombus, and we can see from the T2 weighted image that it has a hyperintense signal, so it is an infected thrombus. And the late gadolinium enhancement excluded sarcoid and other infiltrative diseases. So our diagnosis was that this is an infected thrombus that's causing the showering in the lung, that's causing this pneumonia, and that causing the septicemia. And the decision was that this infected thrombus will not resolve with just antibiotics, and the patient was referred for surgery, and he extracted this infected thrombus, and the patient is doing well now. Thank you.
Thank you so much, dear Ahmed. So it's a very clinically relevant case actually in this COVID era, especially if the patient has COVID, pneumonia, and this mass, which you decided that it's an infected thrombus, which it is. It's a thrombus definitely, but the chicken and egg dilemma. Which one is first? Is it because of the? Somebody may ask, is it because of the COVID itself that causes both pneumonia and the thrombus? As we know, it's a very highly thrombogenic disease, and we know it hits the RV because of the thrombotic lesions in the lungs and so on. So we know that COVID itself causes pneumonia and thromboembolic things in the lung. So it may cause also thromboembolic manifestations like everywhere. We saw the stent case with Julia. Why not that we can say that COVID caused both, and why we say this is the thrombus first, and this is what initiated the pneumonia, not the COVID itself?
So the question is for me or for Julia?
No, it's for you. I'm just saying, direct to you.
So actually the patient was diagnosed with COVID according to the clinical situation, but the swab turned out to be negative, and the blood culture showed bacteremia. So the diagnosis was shifted. Actually, here in Egypt, we usually diagnose the COVID with the CT and the clinical manifestation before going for the swabs, because at that time the swab had a lot of routine. A bad routine to get it in Egypt. So it was late. So we managed the patient as COVID, but actually the swab showed negative for COVID. Maybe he had COVID and then the swab was taken later after the patient diagnosed by like 1 month. And so he was resolving from his COVID, and then he got on top of the viral infection, another bacterial infection. Or maybe it was just a bacterial infection on the thrombus that showered to the lung that gave the picture of the COVID, and there were no COVID at all. It was just a coincidence. At the time of the COVID pandemic, we were all afraid from COVID, and we were very suspicious. Yeah. So we don't know which started first, but we have a negative swab, and we have bacteremia, and then we have patient that resolved after taking out his thrombus from his lung, from his heart.
Actually, you showed very strongly how powerful is the MRI in mass tissue characterization. So thank you so much. I think Ricardo has a message to say.
Rafael, I think he raised his hand.
Yes, no, I was thinking on the swab. Sometimes you have to repeat. I think not always one negative one could be the last answer. I don't know. I think if you have a high suspicion, it's not the. We have patients in our area that at the first time say, "Oh, this is COVID, negative," but 1 week later was COVID.
Yeah. We treated him as COVID because
no, that's the point. That's the important thing, to take all the safety and think always that the patient could have COVID. I think That's the important message. But I think one swap maybe needs a second swap.
Yeah, Ricardo has a message to say unmute yourself, Ricardo, please. Unmute yourself first. Unmute yourself, please. Yeah.
I was seeing all these fantastic cases that have been showed in this session, not only this last one, but all the cases. And I was thinking something that can be a good conclusion of what we have been discussing, which is nowadays we cannot practice cardiology without good multimodality imaging, because we see very often that we usually start with the echo. The echo does not solve does not have all the solutions, and we need to complement the information coming from imaging from echo with the MRI, with the CT, and each case we should know all the advantages and the disadvantages of each technique to improve our clinical practice. And I think this is a clear message that comes from all these cases. The second thing I think is that more and more we should not only look at the images, and we need to integrate with the clinical information. We had several examples today. This last one is also a good example where you need to integrate the clinical information very well with all the data that comes from the imaging. I think this is very clear. And the final message, I think we have a lot of young fellows attending, and I usually say this to my fellows, which is, it is normal to have doubts, especially when you start the evaluation of the patient. I'm concerned when you have doctors that have they know always the diagnosis. It is normal to have doubts. Medicine is not black and white. There are a lot of gray areas in medicine. So it is good to have doubts, to question yourself, look for the best diagnosis, integrate all imaging techniques, because we are better doctors when we have doubts and when we try to reach to the best diagnosis. So I was thinking on all these cases, and I think it is an interesting message to conclude.
Please, Hani, I'd like to also have a comment about what Ricardo said, which is very important here, that I feel like what he said, like the diagnosis or the case is like holes, multiple holes. The multimodality filled these holes and prevented the diagnosis to escape through these holes. So the multimodality fill all the gaps in the diagnosis and let us confirm the appropriate diagnosis and the appropriate management. Here I'd like to, please, Hani, because we have a great experience here with Soha from Aswan Heart Center about the COVID cases. Can you tell us about, because you see in most of cases presented, there is a COVID touches. So we need to know how did the Aswan Heart Center manage such cases?
Yeah, we have 3 minutes remaining for the whole session. So.
Okay. I did enjoy all the cases. Actually, I learned a lot, and I agree with the message that nowadays we have to think about the multimodality imaging in all the cardiac cases. Regarding the specific question about the COVID era and what Aswan do. So actually Aswan is not an isolation center for the COVID, but as many of the hospitals in Egypt, we faces COVID cases. Still, the main presentation is the respiratory. So actually we have the triage or the clinical suspicious based on respiratory symptoms, and still what we see as COVID touch and cardiac patient, as Julia said, the myocarditis. I think one case presented with myocardial infarction. So still we follow what the new guideline, if we say new guidelines or the advices about that. But yeah, still we use the MRI and the clinical suspicious about our cases.
Well, allow me say
again, sorry, Hani, Dr. Ashraf, please. As Julia said, that they are afraid to put the patients on the MRI scanners because of COVID if there is a high suspicious. What do you think about this point? Because I know that you are MRI specialists.
We put them in the MRI and CT, not only for the cardiac problems, but they present with the respiratory or with unconscious. So we put them, but we use the level 3 BEE for the nurses and for the work, and we do disinfection between cases for that. But we put them in the scanners.
Professor Ashraf, please. Professor Ashraf.
Just short comment on the last case with thrombosis. It seems that we have to learn more about the COVID coagulopathy and how to differentiate COVID coagulopathy from other forms of coagulopathy. I think we need the hematologist with us in such cases, and maybe the clue is in the platelet count, in the D-dimer, in the serum ferritin, in the fibrinogen level. With following up of this, we can judge whether this underlying pathology is a COVID coagulopathy, DIC, or other form of thrombotic.
We consulted hematologists about the best anticoagulant for those cases, and they think now that the hypercoagulability in the COVID patients is an acquired antiphospholipid. So they don't recommend NOACs at all. They ask us to give them low molecular heparin or Flexia or unfractionated or warfarin. No NOACs. So that patient was on Ketsam the whole course until the thrombus was removed. Actually, in home isolation, we just give NOACs because it's very difficult for the patient to inject himself the low molecular weight heparin. But the hematologist, they don't think that the NOACs work in the hypercoagulability of the COVID.
But allow me, Ahmed, to disagree with this concept, because antiphospholipid syndrome, there was a 3-case report in the first from China about the high the antiphospholipid parameters, but this is it seems to be a coincidence with the whole clinical picture. There is many other hematological background for the coagulopathy of COVID, which start in a way and may end in a DIC-like picture by the end of the if it is neglected. So it seems it is a big issue, pathology of coagulopathy in COVID patients, and I think it needs a lot of study. But there is guidelines for using low molecular weight heparin, even for NOAC, whether we should give full anticoagulation or half anticoagulation as a prophylaxis for those hospitalized with high D-dimer. And I'm sure this is an important issue in the management of COVID patients.
Okay, great. I think we have learned too much, and or so much we can say. And I'm sure all of us enjoyed the presentations from very elegant experts, Rafael, Julia, and Ahmed. And we're looking forward for the next interesting session. So thank you so much for being with us for this session, and don't go anywhere. Just stay tuned for the second one. Thanks.
Thank you.
Professor Ashraf, please.
Well, welcome back to the second session of this case box wave number 3. Actually, we enjoyed the first sessions, and I'm sure the next will be as fruitful and as enjoyable as the first one. So I leave the mic to Said Farag to introduce the scientific program to Said.
Now I think we have again a bunch of nice cases and a bunch of great presenters and friends. I saw here we have Saraf, it is Egyptian bird in England, and Professor Ahmed Khashaba, Professor Sameh Al-Affas, Professor Nireen Okasha, and my dear friend, also another elegant flying bird in England, Hatem Suleiman. He will be the leader of the coming session, and he will be the session will be co-moderated with Professor Ahmed Khashaba and Professor Raghda Sheikh. Also, she is elegantly presented with us. Sorry, we have a very small notice, then I will leave the mic for our leader this session, Professor Hatem. If Dr. Sara gave us the excuse, and also Professor Sameh, that Professor Nireen, because of special circumstances, she wants to start with her case. Can you excuse us for this, please, Sarah and Sameh? It's okay. So Hatem, take the stage, and you are our leader now.
Thank you very much, Professor Said Farag, Professor Ashraf Rida, my dear friend, Dr. Julia Grabsa. I'm very delighted to be with great friends on this session, the part 2 of the IAVA case box 3, the collaboration between the IAVA and the JAC case reports. And as Professor Farag said, we have very interesting presentations, and we are all excited to listen to our expert speakers. I would like to introduce our first speaker, who is Professor Nireen Okasha, Professor of Interventional Cardiology in Egypt, and she will give us a presentation with the title, Surprises Have No End. Professor Okasha.
Now, can you hear me? Okay.
Yes, we hear you, Nireen. Go on.
You're seeing my screen now, yeah?
Yes.
Definitely, yes. Clear.
Okay, I'm going to present an interesting case, but just a minute. Just a minute. Thank you for allowing me to present my case, and thank you again for letting me start. This is a case. This is a case of an old man. He is 72 years old. He presented to us 10 years ago, but this year he presented with typical chest pain. He is hypertensive for the last 13 years on beta blocker, and he is dyslipidemic on statins, and he is an ex-smoker, but his daughter says that he smokes not in front of anyone. The patient presented with progressive angina and positive perfusion scan. He had the past history that he was referred to us 10 years ago for an elective coronary angiography after somebody else tried to do him from the femoral approach and failed. So they sent him to our cath lab for a radial approach for his coronaries. He had a PCI to his mid-LAD with a bare metal stent that was 10,010. And then again in 2013, he presented with 80% instant restenosis, for which he received a DAS stent, and again an ostial 95% stenosis, and he received a DAS. His general examination showed that the blood pressure from his right upper limb was 210 over 110, and from the other side was 140 over 100. Both lower limbs, he had a blood pressure of 130 over 90. Peripheral pulsation, on the upper left, he had a normal right, but a weaker left pulsation down to the radial pulse. The carotid pulse on both right and left were quite normal. On the lower limb, he had a weak bilateral femoral artery felt, but the pulsation were absent distally. Local examination was unremarkable. He had an audible forced heart sound, and this was his ECG. This is not a great changes in his ECG. And this was his chest X-ray. His echocardiography, he showed that his ejection fraction was quite normal, 70%. He had segmental wall motion abnormality at the inferior walls. He had a concentric LVH, and he had a diastolic dysfunction. His lab was quite normal, apart from his LDL, which was 152 milligram. That's speaking that he was not on a regular statin therapy. This is his coronary angiography, which was done from the right femoral approach on 2010. And as we can appreciate, they couldn't get in, and this was a wire effect that they thought that he had a peripheral vascular disease. But when we filmed him, it was quite normal. The patient was referred for the coronary angiography. We used his right radial artery to do the angio. And this is shots from the coronary angiography. Here we can see his right coronary artery, which seems it had an abnormal origin and this curve here, but it was quite normal. And this was the picture of the tight stenosis of his LAD, for which he received this stent, and this was the picture after the stent. This was on 2013. We can appreciate he had this very severe tight lesion of his ostial LAD. As you can see here, his right coronary was still okay, and he was fixed this drug-eluting stent in the ostium. Let's see the angio from what we did in 2020. The patient, as he presented, was a positive chest pain and positive perfusion scan. And again, he was still smoking, and the statin was irregular. And this was what we found. We found a patent ostial stent, and the mid-LAD stent was okay. And this was his right coronary. As you can see, this severe, almost subtotally occluded right coronary at this segment. It was very difficult intervention. And we had to put another wire in the side branch to fix it, and it was not working. So we had to inflate a balloon during the procedure in the side branch. And then we could successfully deliver the stent after several trials. And this was the final after putting the stent. Of course, this was not the interesting issue about it, though it was a difficult intervention. But let me show you the picture. This patient had a complete interruption of his aorta. He went from the femoral, and we injected. There was no flow going to the upper segment of the aorta and the arch. And then we injected, we went from the radial. As you can see, there is no connection between both the two segments. And this is what I was keeping from you. This is his left coronary. As you can see, the left coronary angiography. And this is the LCX, which is giving a huge collateral, as you can see, and they are forming you see here, this is a collateral from the LAD and then from the LCX, and both conjoined together to form the huge collateral to supply the right subclavian artery. I think here the collaterals are well seen. And this is a still image showing how the collaterals coming from the left and from the LAD and from the LCX and the joint or the huge channel that goes to the subclavian. He had a multi-slice CT. This was done 2010 when we reached that diagnosis. And this is showing the interrupted segment of the arch and the collaterals coming from the coronaries. So he is depending so much on the coronary collaterals to supply the rest of the aorta. I think it is well seen here too. This is the interrupted segment, with absolutely no communication between both segments. And this is the collaterals coming from his coronaries to supply the right subclavian. So this is the sum of the or the summation of the case, and as you appreciate why all his intervention was very difficult, especially the one that I had to intervene with the ostium of the LAD. I had to put a wire and a balloon in the LCX while I was doing the intervention of the ostial LAD, as the LCX is giving the huge or the biggest collateral to the lower segment of the body. So it was going to be a catastrophe if we try to, or if the LCX was occluded during the intervention. This is, as far as we know, is the first reported case of an interrupted aortic arch in an adult, 72 years old. It is a type B, but it was not associated with any structural heart disease, no VSD with him. He had an atherosclerotic coronary artery disease, and the coronary tree is giving the collaterals to fill the post-interrupted segment. As we went through the literature to find this, we found only till now about 50 cases reported in the literature about an adult presenting with a complete interruption of the aorta, and none of those 50 cases mentioned that any collaterals coming from the coronaries. Only one case, they showed a picture of a collateral coming from the LAD, and it was opened in the distal aorta directly. And this patient presented with severe hemopericardium, which was the cause of his death, and they found this post-mortemly. But all the other cases, none of those cases reported that the collaterals coming from the coronary arteries. And this a short resume about the interrupted aortic arch in an adult, which is an extremely rare case. It is a rare heart defect actually, and represent 1% of all the congenital heart disease. It's associated with additional cardiovascular anomalies defect in 98% of cases. Only a few cases of interrupted aortic arch in adult have been reported, as I mentioned. The collateral circulation must be very well to supply the lower end of the body. The types of the interrupted aortic arch is type A before the vessels of the arch, and type B, which is the commonest, it is almost 50%. Type A is 45%, and type C is the rarest presentation, which is the interruption occurs proximal to the origin of the left common carotid artery, as we can appreciate from this picture here, or from this drawing. This is another drawing. And almost type B, in almost 99% of cases, they have to have a VSD, but in this case, he didn't have a VSD. And this is my team at Nasser Institute, and thank you very much.
Thank you, Professor Okesha. That was a wonderful case, by all means. Fantastic. I mean, the novelty and the complexity of management, and as you've said, not only the complexity of the finding, but the complexity of managing the coronary problem in these patients. Do we have idea about the survival of those patients with interrupted aortic arch? Do we have an idea about what's the percentage of those who grow until adulthood, and if there is any surgical option for those who has any, who sustain symptoms or any problems while they grow up?
Actually, they are very rare to live to the adult life, and when they are usually if they are diagnosed, it will be early in their life, and they will have to undergo surgery to put a conduit between those parts of the aorta to complete the circulation. And this was why this case is very rare. And actually, this patient, it was discussed first when we reached the first diagnosis in 2010. We had a heart team meeting to see what we can do about it, and all the cardiothoracic surgeons, they agreed that it will be extremely risky to open this patient, especially that he's a manual worker. He didn't have any complaint during all his life. He was working with his hands. He's not stunted growth. He had a complete family with 4 kids, and he never had any problem with this complete interruption. So they said that if they try to open the chest, maybe they are going to cut through the thoracic collaterals coming from the mammary arteries or something like this. So they refused to do anything as regards surgery. And I agreed actually with them, because I didn't think that he is suffering. He had well-developed lower limbs, well-developed upper limbs. He was functioning almost normal, apart from his coronary problems that was causing his chest pain and was letting him not go to his usual work.
Wow, that's fascinating.
Hatem, if you allow me,
Can you
please,
allow
Hatem.
me for question?
Dr. Raghda, I will give me a short comment or short question to because I'd like to take the privilege to ask Sarah. I know she is expert in MRI, and I know this. Nerine discussed this case with me before, and I'd like to ask you a question about: is there any rule for the MRA in properly diagnose and properly localize the coarctation, the complex anatomy? If there is any rule here for the MRI and MRF in this case?
Yes, absolutely, because it does help to differentiate if there's any differences in velocity and to suggest whether there's significance in loss or not. We can see a diastolic tail, which we can clearly see. And it also gives us an idea within MRA. We can do contrast and non-contrast MRAs to show the site, the location of the coarctation, the distance to the left subclavian, in order to plan for what type of intervention can be done, as well as to follow up patients who have previously undergone surgery. MRA and cardiac MRI is also important in patients that I do scanning for coarctation, because I also do every 10 years, we also do a Circle Willis, because lots of these patients are predisposed to cerebral to bury aneurysms. So actually in this case, I was thinking this interrupted arch, has he ever had an MRA?
No, he didn't.
Of his head?
No, he didn't.
It might be worth considering. I know it's not a coarctation, but given the interruption, because there's information literature that we've noticed, even in patients that have been treated with coarctation, that they tend to have, not because of cerebral aneurysms or hemorrhagic strokes, but also these patients do tend to have increased risk of strokes in general in coarctations. I'd have to check. I'm not sure what the data is for unrepaired interrupted aortic arches, but we know from the data from the coarctations that these patients have increased risk of developing atherosclerosis 10 years younger than their other age-matched and gender-matched people from the general population.
Maybe, Sarah, because he's 72 years old and probably had aneurysms or Circle Willis, which is liable to rupture, it would have been shown itself till now. But as he is living till the age of 72, and I don't believe we will find something, but it is worth that to complete the study at least. Maybe we will do.
I know, absolutely. I totally agree. And maybe that's why he presented earlier with ischemic heart disease earlier in life. You mentioned 10 years ago.
Professor Raghda had a question, I think.
Yeah, I have a question for Dr. Nerine. Dr. Nerine, very, very interesting case, and yes, it's a very, very rare case. But I would like to ask you if there is any possibility to put covered stent after perforation of this total interruption aortic arch. We hear a lot last years about wire perforation or laser perforation for this total interrupting aortic arch, and then we can put a covered stent between both two segments, and we can avoid the patient all the risk of cardiac surgery. If there is any possibility at that old age and at that situation to put a covered stent between these two different segment or totally interrupted segment, and we can keep the original anatomy for these patients.
Actually, we discussed this, but we have a lot of problems. First of all, maybe we will do this in a child. We will have the covered stent, which is appropriate size. Now his aorta is in the adult size. Maybe it is about 5 or 6 even centimeters. I don't believe that we have a covered stent with this size, so we'll have to make one especially for him. But why would we do it, especially that he doesn't have any problem? We will do this if we have an ischemia of his lower parts. It's affecting his growth, it's affecting his function. But apparently he has enough collaterals to support the circulation post-interrupted segment, so that's why he's not complaining. So just doing any intervention about the interrupted segment, I don't think we are going to help him, as actually he has no complaint about this. This interrupted segment is not causing him a problem. So I don't think we should treat it.
Yeah, thank you.
Thank you very much, Dr. Kesha. We have to move on for the sake of time, and now it's time to go for the next speaker, who is Dr. Sameh Al-Kaffas, who will give us a presentation on lesion length in CTCA-guided PCI. Dr. Sameh.
Okay, thank you, Dr. Hatem, for the nice presentation, and I have to thank Dr. Reed. It's an amazing case. I will share my screen now. Okay, is that clear?
Yes.
Okay, so my presentation is about lesion length in CT coronary angio guided PCI. I'll start with a confession. My case is not a case report kind of case, and it's definitely not a COVID case. So rest assured, we will be free from COVID, I think, in this session. But again, it will shed light on some, I would say that we will be missing in our practice using the data from the CT coronary angiography in guiding PCI. I'll start with some basic facts that conventional angiography has some blind spots, being only a two-dimensional immunography, like osteal lesions, the total occlusions, positive remodeling concept, the plaque extent and morphology, true lesion length because of the foreshortening that happens in conventional coronary angiography, and functional significance of borderline lesions. For the sake of this presentation, we will be discussing in detail the plaque extent and morphology and plaque length and the true lesion length because of foreshortening. I will go by osteal lesions. This is a major deficiency of any two-dimensional imaging because as in this image, we can see that it's clear that this is maybe the bifurcation site. However, in reality, the bifurcation is on the other side of the artery, and we cannot really see it because of the limitations of a two-dimensional imaging technique. While in a three-dimensional imaging technique, we can very easily get an osteal lesion. Total occlusion, needless to say that CT coronary angiogram has the upper hand in delineating the occluded segment, as we can see here, its course, the presence of calcifications, and so on. The positive remodeling concept in the plaque extent, as we can see here, that the artery can have a large amount of an atheroma without really encroaching on the lumen. But again, another important thing is the length of the plaque. As you can see in the image in the lower hand, right side of the right-hand side, there we can see the wall of the artery itself, and seeing the wall of the artery itself is basically an important part to determine the exact length of the plaque and where it is located, and of course the constituents of the plaque. Foreshortening is a major deficiency again for two-dimensional imaging because as we can see here, you have to be directly perpendicular to the segment in question so as to have 0% foreshortening and so as to be able to determine the exact length of the segment in question. And you can overcome that during PCI by getting a perpendicular plane as much as you can on the segment of the artery, and you can use QCA, quantitative coronary analysis, to determine the length of the lesion, or sometimes we use the markers, for example, the radio-opaque wire segment or balloon markers to determine the exact length of the lesion. And in IVUS, we can see the wall itself, we can see where the plaque starts, where it ends, the proximal landing zone for a stent and the distal landing zone, and by using automatic pullback, we can determine the exact length from the start to the end of the plaque. So a lot of extra equipment may be needed, for example, to get that really right. And it is important. This is a recent meta-analysis comparing in IVUS guided angiography, guided PCI versus angiography guided PCI. And as we can see here, lesion length, the longer the lesion, the more the impact of a detailed imaging technique like IVUS on the outcome. This is, we are talking about MACE, and it becomes really significant the longer the lesion, because it is really important in these kinds of lesions to determine the exact landing zones for your stent. Now we have new tools like the co-registration using IVUS and superimposing that on conventional angiograms. And as we can see here, we can determine where the plaque starting, where it ends, and we can use that to determine the exact lesion length and plan the stent length. And even tri-registration, where we can use not only the length and the anatomy or the anatomy of the vessel wall we can see in IVUS, but we can integrate that with the IFR and estimate increase in the IFR after treating that kind of lesions. So we have new tools now for interventional cardiologists. For example, we can use the images from the CT with special software to determine for each segment of the coronary arteries which are the views that we can use in the cath lab to get the least foreshortening. And I think this is important to save contrast and radiation exposure to the patient. And we can, again, co-register that on the images from the conventional angiogram. So for a certain lesion in a certain segment of the coronary artery, we can determine which view or which projection can give us the least foreshortening, and we can use then the data, whether from the CT or from QCA, for example, to determine the exact lesion length and also the exact stent length. And we can use that. We can use the data, again, co-registered from the CT angiography and the conventional angiogram to determine the lesion length. And even that can be integrated into the cath lab, and we put that in the cath lab. And so we have new skills. I agree with Ricardo, and in the end of the last session when we were saying that multimodality now is the name of the game. You have to be familiar with the different modalities and how to use these to guide your procedure for structural heart disease and again for coronary artery disease. My case is in clinical practice. This is one of my cases. He's a male patient, 47 years old, who is a chronic heavy cigarette smoker, not diabetic or hypertensive. He was presenting with recurrent episodes of typical chest pain. However, his cardiac biomarkers, ECG and echo, were within normal. So a multi-slice CT coronary angiogram was ordered, and it came out like this. As we can see here, we have a focal lesion that is very much significant in the proximal part of the left anterior descending artery. And that was proved true by the conventional coronary angiogram. And we can see that significant focal lesion in the proximal part of the left anterior descending artery. This view, the spider view, actually presents us to a dilemma that sometimes we face in the cath lab. As we can see here, we have discrepancy in size between the landing zones. What we usually have is a larger proximal landing zone as compared to a smaller or a less in diameter distal landing zone for the stent, as we can see here. So the question is now, is that larger distal landing zone for the stent, is this an ectatic segment and we can go focal, or is the artery diseased from its ostium from the beginning, and it's the true exact diameter of the artery is that one in the distal landing zone? So I was contemplating this, okay, maybe we'll be needing an IVUS to determine where to start and where to land. But again, we do have the data from the CT coronary angiogram. So back to the CT coronary angiogram, this is an oblique view. This is a different view. And let me expand this or zoom on this. We can very clearly see here that the plaque is actually starting from the true ostium of the LAD. And this is one of the rare cases we do not see the disease starting from the left main. So this plaque is starting from the ostium of the LAD and becomes very significant in the proximal LAD. And then it is followed by this looks like this is the normal diameter of the LAD in the distal landing zone of the stent. And so we went ahead and I used again to double check the wire to measure the stent length, and stent was employed respecting the diameter of the distal segment, and the final result was, I think it was very satisfactory, and it respected the true diameter of the artery without using extra equipment like an IVUS catheter. And this is supported by the literature for there is not too much data on the literature about the comparison between CT coronary angiography and conventional angiography about the lesion length. And this is from 2012. And as we can expect, the lesion length in CT angiography is significantly longer than in QCA, depending on the two-dimensional conventional coronary angiogram. The difference is actually quite large. It was 8.8 plus or minus 6.7 standard deviation, and that was significantly longer. Interestingly, in this study, they found that the lesion length visualized on CT angio was also significantly longer than the mean stent length. And that again was statistically significant. And even the operators who had the insight to use longer stents to try to respect what they see in the angiogram and the normal to normal, again, they fell short of the length of the lesions that was described in the CT angiogram. So my take-home message is, do not treat CT coronary angiography than just a go-stop sign for conventional angiogram. There is a lot of data in that, already available data in the multi-slice CT coronary angiogram that will make your life much easier in the cath lab if you use that to plan your PCI properly. And do your homework, you can increase your efficiency. You save yourself time and effort. More importantly, you save your patient contrast and radiation, and much, much more importantly, increase your success rate and improve the long-term outcome for the patient. And with that, I end my case, and thank you for your attention.
Great. Thank you very much, Dr. Sameh,
Thank
for
you.
Elegant presentation and a new perspective. And probably it's an opportunity to take the opinion of our intervention experts, Dr. Ahmed Khashaba, and see if he has any thoughts on this. Dr. Ahmed.
Thank you so much for inviting me for this elegant gathering. And actually, the talk was fantastic by Sameh. He covered almost everything. And the role of CT in determining the length for the lesion and take extra data to plan the procedure is invaluable. Back in the old days when we started the CT program, I was providing the length of the lesion in the report and the best angle view to see this length. And I was mentioning from healthy to healthy is like 30 millimeters or whatever, just to guide the operators to use this. And back at the time, there was no great trust in the CT measurements, but as the data came along and as we experienced this, it's a very invariable tool. And I think it's the only comparable technology to IVUS. So if you really want to check and have a good planning, pre-planning, CT is invariable in this regard.
Thank you, Dr. Ahmed. If I have just 1 minute, interestingly, I was just talking with Dr. Ahmed Khashaba yesterday about a case he sent to me because she was a lady who had acute chest pain and he was no significant changes in the ECG. If you allow me, Dr. Ahmed, to share this case with people, just to highlight that there is much more data in the CT than just the coronaries. And he told me that he needs an answer for this patient. The ECG is not there and no changes to start with, and the patient is in severe pain. Her echocardiogram turned out quite normal, and he sent her for both because he was suspecting from the site of the pain that it may be an aortic dissection. So I sent her for a CT coronary angiogram and a CT aortogram. Interestingly, both turned out quite normal. There were maybe some mild plaques in the coronary artery that did not justify or definitely were not responsible for that kind of pain. And I noticed that the esophagus is much more thickened than usual. And in the aortogram, we found a pancreatic mass, head of pancreas mass, and that was the first time that we diagnosed for this patient that she's having some another cause for her chest pain than the CT or the coronary or the aortogram. More of the story is there is much more data in CT than just the conventional angiogram. So you have to be very judicious. For example, this case, if we're just telling Dr. Ahmed, no, your case has nothing significant in the coronary, not significant in the aorta, you should have missed the real important, the life-threatening condition for the patient. So CT has a lot of data. You have to be trained how to read everything, not just the cardiac or the great vessels, but also the extra cardiac things. because this may allow, not maybe as dramatic as yesterday's case, but even simply a small hiatus hernia can be the answer to the patient's complaint. So we have to use all the data we have for the most benefit for our patients. And thank you. I'll not take much more of your time.
Great. Thank you very much, Dr. Sameh. That was fantastic. And for the sake of time, it's now time to move forward for the next and last presentation for this session with a great dear friend and colleague, Dr. Sara Muharrem Al-Gamal, who will give us an interesting highlight into a complex adult congenital heart disease patient. So up to you, Sara, now.
Sorry, I'm going to mute myself. Thank you so much. My name is Sara Muharrem Al-Gamal, and I would like to thank Dr. Farag, Dr. Grapsa, and Dr. Rida for their kind invitation. I'd like to congratulate Dr. Okesha and Dr. Afas at their great cases. So in adult congenital heart disease, a lot has happened over the past 70 years because of considerable development in the management, in the diagnosis, and the management of these cases had led to increased survival of these patients living to adulthood. In the 1940s to the 1959, only 60% were increasing to adulthood, and then from 1980 to 1999, now 87% were living to adulthood. So this is just to set the scene of the case that I'm discussing today. So this case is from the Bristol Heart Institute when I was working over there as an ACHD fellow. And this was a 53-year-old woman presented with increasing breathlessness over the past year, presented with NIA class 3, experiencing increased shortness of breath. She did also have complex congenital heart disease, which is, as we can see, she has a background diagnosis of being born with tricuspid atresia and pulmonary atresia. She had undergone a Brock procedure, which is a closed pulmonary balloon valvotomy at the age of 2. Then she had undergone a classic right BT shunt in 1970. She had undergone a AP Fontan, in which the right atrium is connected to the pulmonary artery at Ormond Street in 1975. She then needed a redo Fontan surgery in 1988, and excision and repair of the right atrial to PA tract with a Gore-Tex patch was done, as well as thrombus excision and ablation of any Fletcher pathways. She has a bicuspid aortic valve, and she was being treated for hepatitis C and was receiving antiviral therapy, and she's known to have a low platelet count. And if we look at the echo images, in which we can see here that there is, we see here first that she has a single left ventricle, in which appears to be a good radial function, but longitudinal function is down. There is some mild LV hypertrophy, as we can see in these panels. In the lower right panel here, we can notice we have a thickened aortic valve with restricted systolic opening, and the aortic valve maximum velocity was 4.6, and the LVOT Vmax was 0.6, in which this gave a gradient of 85 millimeters mercury and a mean gradient of 50 millimeters mercury, and she had mild aortic regurgitation. On looking back at her serial transthoracic echocardiograms in 2011 and 2012, her aortic valve Vmax was 2.6 and 2.5. In November 2014, there was noticed that there was an increase in her gradient and the maximum velocity. And it was decided to be discussed in 2014 at the multiple disparate team meeting. But given that at the time that she's known to have complex congenital heart disease, she has liver cirrhosis, and she was asymptomatic, it was thought just to follow her up for 6 months and review her in clinic and have her new follow-up. But she was not seen until February 2016 because of social circumstances, and she was undergoing therapy for her hepatitis C, and she was receiving quite a lot of antiviral therapy. And she initially thought that the shortness of breath was related to the antiviral therapy, rather than her heart condition. I think I might have missed a slide. I don't think I can go back. Can I? Yes, sorry. On clinical examination, I should have showed this before that. I might have pressed the wrong button. Her height was 152 centimeters. Her weight was 58 kilos. BMI of 25. Normal blood pressure. Her heart rate was 60. Normal volume and regular. Her SATs were 91%. And looking at previous clinical letters, her SATs were higher on room air, which are usually 96 to 97%. She had a previous 2 scars on her chest, which were lateral thoracotomy scar and a median sternotomy scar. On cardiac auscultation, she had a normal heart sound, a single second heart sound, a harsh ejection systolic murmur at the left peristernal border, grade 4 out of 6 propagating to the neck. Her ECG was sinus with abnormal PR interval, borderline LVH, and diffuse T wave inversion, and the echo findings as I have described. The bloods that were taken when she was seen in clinic in that last visit in February 2016, the remarkable findings were that she had a low platelet count. Her INR was 2.4, which was therapeutic as she was receiving warfarin. Her bilirubin was slightly elevated to 27, and her total protein and her albumin were normal, as well as her liver enzymes were normal. And let me just see here. And another MDT discussion had taken place with ACHD cardiologists, ACHD surgeons, anesthesiologists, and radiologists. And potential management options were discussed as regards for TAVI or undergoing a surgical aortic valve replacement. In this patient, because she has congenital heart disease, the usual logistic EUROS 2 scores or the ACC adjusted TAVI risk scores don't really reflect patients in this population. And there was a shared discussion making, and it was decided that the patient, a discussion was taken with the patient, and it was decided that TAVI would be done with, but proper pre-procedure planning would need to do that with the possibility of surgical backup. And we can see here, this is her cardiac CT, in which we can see here the patient has a bicuspid aortic valve, in which we can see that we can see here that there's calcification along the line here, and we can note fusion of the right 9 cusp. There is a favorable, I think somebody's not muted. And we have a favorable annular aortic angle. There was also a favorable annulo-coronary distance, as well as a favorable annular diameter. We can also notice here that the patient has a dilated coronary sinus, as the patient has a left SVC, which I will indicate why this is significant in this case. In the CT view that we also had done, it was not optimized to see the Fontan circulation, so we cannot assess the Fontan circulation for thrombus. On her chest X-ray, as she had developed prior being brought in to TAVI, to be TAVI by 2 weeks, she developed increased symptoms of heart failure. And this is what she had presented, her chest X-ray she presented at the time, and we can see we have right-sided pleural effusion, levocardia, cardiomegaly, and a right atrial pacing lead. And on her ECG, she was an atrial flutter. And in this patient, it's very important for any patient with a complex adult congenital heart disease to maintain normal sinus rhythm. She underwent a successful electrical cardioversion. She then underwent a TAVI procedure in which an ACHD interventionist, an ACHD surgeon, as well as the device specialist were all present. And the significance here is that usually in TAVI, they pace the RV, but this is a patient with a rudimentary right ventricle, and you really can't pace the RV. So the pacing lead was placed into the coronary sinus. And the things we know when we rapidly pace patients who have in TAVI, who have a poor right ventricular function, can be quite tricky. So we didn't really know what it would be like pacing a patient who doesn't have a functioning right ventricle. As rapid pacing, it diminishes the cardiac output and it can cause transient hypotension. A Medtronic core valve was successfully implanted, 29 millimeters, but the patient had developed complete heart block, and it was decided because as the coronary sinus leads, it was not quite reliable, making sure that it was steady in its place. So it was decided to do a permanent epicardial pacemaker was put in, and that was the importance of having the surgical as well as the pacing specialist backup. This patient was able to, the pleural effusion had resolved by 2 days, and by 7 days, she had gone home. At 30 days post-TAVI in clinic, she'd gone from NIA class 3 to NIA class 1. She was able to walk up to 3 miles in a day. Her SATs had improved to 97%. And we can see here on the CT images that the TAVI, the evolute valve, is in good position. On her echocardiogram, the aortic valve Vmax was 2.3 meters per second, mild AR. She does, however, in the period of having the procedure, her INR was subtherapeutic. So we do notice that there is some thrombus here in the right atrial appendage. And the take-home message from this is that patients with adult congenital heart disease, complex adult congenital heart disease, particularly patients with a Fontan circulation, changes in afterload are poorly tolerated. Complex decision-making in older Fontan patients with comorbidities requires a multidisciplinary team discussion, a heart team discussion. Pre-procedural imaging in TAVI is crucial, and atrial arrhythmias in ACHD population reflect worsening hemodynamic status. It's also important to notice the complexity of pacing in patients who have a Fontan circulation and to be able to anticipate the need of putting an epicardial system. TAVI is a potential therapy in complex congenital heart disease who have multiple comorbidities. And this case was published by my colleagues in Bristol in 2016 in the International Journal of Cardiology. And this is our paper that we have submitted. This is being submitted for a publication. So this is initial study about the feasibility and effectiveness of TAVI, aortic valve implantation in adults with congenital heart disease. And thank you.
That was excellent, Sarah. Very nice case and challenging topic for all of us. Probably the most complex of all. I have a quick question for you before I invite my colleagues in the panel. What do you think is the chance of this patient to have a heart transplant, looking at the multiple operations that she had, and I'm sure she had a lot of blood transfusions. So do you think she will have a chance if she needs heart transplant in the future?
I think it's possible. I think unfortunately they would have to do the LHA typing, but I mean, I think at least the TAVI procedure saved her one less procedure that she didn't have to have a blood transfusion. And she's only right now, she was 50, in her early 50s. And as you know, in the UK, that transplants are done up to the age of 65. So there's a possibility that if she were to need later in her life, that could be a potential option.
Great. Thank you. Any question from our panel? Dr. Farag? Dr. Grabsa?
Personally, I would like to say that congenital heart disease is extremely difficult for all of us who are not actually congenital specialists. I know that it takes 1 hour, 2 hours to see a patient, and I'm very surprised at how the transcatheter interventions that 10 years ago we were studying them and understanding the imaging, how now have become a great tool for these patients that you would not dare actually to take them to the operating table. to theaters. So it's very impressive, and I think there is a great future for these patients to undergo transcatheter therapies, or not practically opening their chest. So, Sarah, that was an amazing case, very impressive, really well done.
Thank you.
I think we have one of the congenital experts here with us, Professor Raghda, and I think she will give us her thoughts about this case also. It's really fantastic. It is really showed us how imaging can fill the gaps again for the diagnosis, for the plan of management, especially that these cases in 2016, as Sarah said. Please, Professor Raghda, can you share us your thoughts about this case?
Yeah, first of all, congratulations, Sarah, for these highly interesting, highly impressive cases. Actually, the role of imaging modalities here is highly important because we use aortic valve replacement out of label. As Sarah said, her case was bicuspid aortic valve, and till 2016, the bicuspid aortic valve considered relative contraindication for aortic valve replacement transcatheter. So the use of aortic valve of label in such a case is a life-saving and considered highly fantastic, Sarah, actually. But I want to ask you, what about the CT branding model in this case? It's safer for the patient to use this branding model before putting aortic valve in such a case? This is one question. And the other, what is the role of balloon sizing in such cases? Is it play a role before also putting aortic valve in such a place, and we can avoid by balloon sizing the possibility of coronary obstruction or complete heart block or this complication of arrhythmia?
So thank you so much for your questions, and I really appreciate your input and your feedback. So this case we did do, the CT was able to provide us, I wasn't able to show all the images, but the CT was able to provide us with the distance between the, we do measure the cusps of the aortic valve, the diameter of it, as well as the annular to coronary distance by CT. So that allows us to assess that there's going to be no coronary obstruction and that it was safe, and it was a safe, good distance. As regards to the planning of the annulus, there is some new guidance in which we can use the CT to help plan the sizing of the bicuspid aortic valve annulus. I'm not an interventionist. I'm an ACHD cardiologist as well as an imager. As regards to possibly they might have used balloon sizing in the valve to, in the procedure to check. I have to say I don't know, but I know that the annular dimensions by the CT did correspond with what was planned, which was planned to use a Medtronic core valve, 29 millimeter. So that was what was planned.
So Sarah, I do have a question. I'm Samah Al-Qafas. Sarah, how are you? Long time. Okay. Since you're having a paper going on for that, it's a very interesting topic using the TAVI for adult congenital heart disease patients. Is there any preference for the kind of valve? Is the balloon mounted or the self-expanding ones? And that was a rather big valve. Yeah, self-expanding or better. And that was a rather big valve, actually, 29 valve for a lady, or a 55-year-old lady. That was a rather big. Does this has to do with it's a bicuspid valve or the annular sizing?
It's a bit of both, as well as it's a bit of both, and also because the idea was to use a self-expanding valve because instead of to dilate, just to put that self-expanding valve in. So, yeah.
Okay, interesting, because it's just as you said, it's very tricky. Because the anatomy, the usual anatomy is not there. Using the coronary sinus was a very clever trick to do the pacing because there is no actually.
There's no right ventricle. Exactly.
I have a comment.
So why not use the lead that was already present in the right atrium? So what did you go for?
It was thought that this would provide. Well, you could argue that that's true. But there was easy access through the left SVC and be able to control. So it was easy access. It would just, when she happened to complete heart valve, it would just feel that that would provide something steady and something reliable pacing for something permanent. So
very interesting case as usual, sir. Thank you.
Sir, I have a question about the what are your thoughts about the long term for the TAVI valve in such a cohort of patients?
So right now we did the our study that is, you know, it's under submission, it's still under review. We haven't, so all the cases that I have found in the literature when writing up this discussion, we've only found 4 cases in the literature that are purely congenital, not Turner's, not Marfan's, not any aortopathies. So far, all the cases that we have seen, maybe only 1 has developed moderate AR after 2-3 year follow-up. The rest have less than mild or trivial AR. A lot of them are bicuspid aortic valves, but so our study, we didn't just include patients that had bicuspid aortic valve. They had to have a complex underlying congenital heart disease. There are some patients in which there was complex congenital heart disease, had a homograft with a totally calcified aorta, in which we also, TAVI was produced. I really wish, the cardiologist who did this was Dr. Mark Turner from Bristol. So he really is an eminent ACHD interventionist as well as a structural interventionist. He's absolutely phenomenal. He's the one who did all these cases.
Well done. Yeah, thank
you. Thank you, everybody. I think it was a wonderful night, wonderful cases, wonderful and elegant bunch of colleagues and professors. I'm really feeling happy about these cases, and the educational messages came from it, from the multimodality imaging, filling the gaps in the diagnosis and prepare for the plan for management. The only one thing in this night that Julia is wearing a red suit, which is the color of my contra team, which is Ahly, because I'm supporting Zamalek, which is wearing the white suit. So this is the only thing in this night, but it's very fantastic. Thank you, Julia, very much. Thank you for cases. Thank you for your wonderful colleagues from JACC Case Reports, Ricardo, Rafael. It's really wonderful. I'd like to leave the mic for you to conclude this wonderful night.
So thank you very much, all of you. It has been a great session, wonderful cases, wonderful colleagues. So I will say that now we have an established collaboration between EAVA and JACC Case Reports. We will be here for you when you need us, and vice versa. Good luck with your team. Good luck with the game tonight. I wish you all, I bring good luck to football matches. So I promise to you, you will win. So thank you very much, all of you. And it was great to meet with you all.
Sayed, I'd like to take the chance to say happy birthday to Sayed. I think his birthday was yesterday.
Happy birthday!
Thank you very much. All of you said it to me, and I'm really happy about it.
Happy birthday, my friend.
Thank you very much, my dear. It's a really wonderful night. Thank you, Sameh. Thank you, Raghda. Thank you, Hatem, Khashaba, Sarah, Nireen, everybody who will be with us now. Thank you, Julia. And I'd like to conclude that we planned for the coming year with Julia to be about 4 waves in JACC Case Reports and EAVA Case Fox. And I think the coming year will be much more better, inshallah. Thank you very much, everybody.
Thank you very much.
Thank you. Have a nice night. Bye-bye.
Have a great night. Bye-bye.
Happy birthday.
Happy birthday.
Thank you very much. Thank you, Raghda. Bye-bye.
Bye-bye.
Bye-bye.